Welcome to Breast Cancer Grand Rounds. I'd like to acknowledge the traditional owners of the land on which we are currently located and meeting, paying my respects to their elders past, present, and to any Indigenous people present online. As always, it's a great pleasure to invite people, to welcome people to Grand Rounds. Looking forward to this very much. We will have time for question and answers. Please put your questions in the Q&A function during the meeting, and then we'll have time after the talks. Today's Grand Rounds, we have two speakers, Professor Carolyn Nickson and Dr. Pietro Procopio. I've been working with Kaz and Pietro for a number of years on the possibility of risk-based breast cancer screening in the Australian setting. When I say I've been working with them, they've been doing the work and I've been very interested in the work, and it's been very encouraging the way that this work has progressed, and also the way that the concept or the need to move to risk-based screening is being increasingly acknowledged and adopted both here and internationally. So I think we'll first have Kaz will give a presentation, then Pietro, then we'll have time for discussion. So welcome and thank you, Kaz.
Thanks very much, Bruce. And thanks to everyone who's joined us today. Share my presentation. So as you will have seen from our abstract, we'll be covering 3 topics today under the banner of risk-based breast cancer screening. One, trying to share some insights from some of the work that we've been doing in this space over the last few years. Firstly, just thinking big, when we think about early detection of breast cancer, the reason we try to find breast cancers earlier, and ideally before they become symptomatic, is because that increases survival, but also it reduces how intense and long treatment needs to be, and it reduces the long-term impacts of that treatment, so avoiding things like long-term lymphedema. The ways that we find breast cancer earlier is through prompt clinical investigation of symptoms, but also through population screening of women without symptoms through the Breastscreen program in Australia, and through surveillance of asymptomatic women at higher risk outside the Breastscreen program. And this is a language that we've sort of come to use to differentiate between those 2 areas of services, screening and risk-based surveillance. There's real changes in the landscape for breast screening and surveillance. We have new methods for assessing breast cancer risk and risk of interval cancers, and these are increasingly validated on large populations. New technologies for screening and surveillance. Genetic testing is now becoming more widespread. Women are wanting more personalised healthcare. Some women are concerned about breast density in particular. And data processing has evolved so that now we can really dig in and pull together evidence and to find solutions through methods like population modelling, artificial intelligence, and image processing. So how can these advances be used to find breast cancers earlier than currently? I recently gave a seminar about the ROSA project through the UMCCR. That's now available online if you would like to watch that whole presentation. It gives an overview about the whole project and all the different aspects of it. But I did just want to cover it here because this is the context in which we are doing our work. This is, we're funded by the Australian Government Department of Health, working as the Daffodil Centre, which is a joint venture between Cancer Council New South Wales and the University of Sydney. And we're doing that work for Cancer Council Australia. We are governed by a project coordinating group and an expert advisory group, and we also engage regularly with Breastscreen Australia. And what we're doing is we are exploring options for more risk-based, personalised approaches to the early detection of asymptomatic breast cancer in Australia, looking at both population screening and risk-based surveillance. We have a website for our project, and you can see here the web address and also a contact email if you wanted to send any inquiries. And an enormous team of excellent researchers working on this project. The activities under the project are summarised here. So we have scoping and systematic reviews, environmental scans, a review of international trials and consideration of how they might translate to the Australian setting, specific modelling and epidemiological studies, working with the AHW on options for enhanced data collection and reporting perhaps in the future, and putting together a regularly updated roadmap and recommendations. Now, the items that are there in green are the ones that we'll be doing a little bit of a dive into today, just to sort of give an indication of some of the work that we are doing in more detail. So firstly, looking at clinical services related to risk-based screening. Often when people think about risk-based screening, they immediately think about Breastscreen Australia, and rightly so. It's a very effective program introduced in the 1990s following evidence from trials that screening could reduce mortality, and that mortality reduction has been demonstrated in Australia. About 55% of women in the target age range of 50 to 74 years participate in the program. And it has extraordinarily high quality data that it collects and reports, and has done so for nearly 30 years. And these monitoring reports assembled by the Australian Institute of Health and Welfare are incredibly rich. So we have this amazing oversight. We have over half of Australian women in the target age range participating in the program. Outside Breastscreen, there are a number of services that are involved in risk-based surveillance for breast cancer. There are family cancer clinics, primary care services, primarily GPs, breast physicians and surgeons, and private breast care centres. To support particularly GPs, there are Medicare items specifically for asymptomatic women, and also for women at very high risk. We conducted an overview of these clinical services as part of the ROSA project, as part of a sort of foundational exploratory program of work then, looking at the different services involved in screening and surveillance and how they interact. And this is a diagram that was made before the COVID pandemic came to be. So a graphic we might need to redo. So we reviewed each service in terms of the services, the current risk assessment and advice in those services, how risk information is recorded, the information that's available on rates and trends in service utilisation, so trying to understand who uses the services, where the disparities might lie, how they're funded, how women enter and exit those services, and how those services align to their relevant clinical guidelines. So this is a comprehensive report. It's sort of maybe 80 or 90 pages long. I just wanted to give you a little bit of a snapshot about some of our key findings. So firstly, in terms of what motivates women to screen with Breastscreen, women are invited at the age of 50 from the electoral roll, and they're re-invited, and a letter is sent to their GPs after screens. Various studies have shown that women are more inclined to screen if they have an understanding of the benefits of screening, if they're exposed to Breastscreen communications, with encouragement from family and friends, with recommendation from a doctor, recommendation from an Aboriginal Torres Strait Islander health worker. Family history is really, as many would know, perceived in the community as a key predictor of breast cancer. And that can actually have the effect that some women figure they don't need to participate in screening because they don't have a family history. But of course, many cancers arise in women without a family history. And women who in the Breastscreen target population who participate regularly in cervical screening are more likely to participate in breast screening. So these are things to consider. If we're sort of thinking about risk-based screening and risk-based surveillance, who are the women who already come to Breastscreen, and how might risk-based screening impact those women and their decisions to screen and how they engage with other services? Some work in New South Wales looked at underscreening. So that included both women who never screen and women who screen but don't come back. And they found that underscreening was more common in women who were in higher socioeconomic areas, but also among lower income women, women who work more, women from cold backgrounds, Indigenous women, women who don't provide GP details at the time of screening, maybe that's about the letter or about something else, women in remote areas, and mixed results on whether women attended screening through fixed sites or through mobile trucks and vans, mobile screening sites. So different results in New South Wales and South Australia. Women aged in their 40s can participate in the screening program. They're more likely to have a family history of breast cancer, to report breast symptoms, to have a higher perceived risk of breast cancer and a higher education level and a lower disadvantage score. Within the Breastscreen program, most women are offered biennial screening. However, some women are offered annual screening, and the policies by state and territory are shown here. Well, not the policies, but the information that's used to determine whether women might be offered annual screening based on their risk. And you can see there's a little bit of variation there, and particularly around whether ovarian cancer history is taken into account and whether genetic risk factors are incorporated. Breastscreen reports the number of annual screens, but not how many women are offered at annual screening or the uptake rates. Overall, work on Breastscreen through this perspective, we find there's really good standard methods for recruitment and re-invitation, despite those variations between states and territories. It's all very sort of clear and quite well recorded. There's regular risk assessment for annual screening, different policies for annual screening, but they're very, very similar. There's very high quality monitoring and reporting. And there's some referral to and from other services, which I didn't quite cover here, but some women might be referred to their GP or for high risk assessment. And there are some disparities in access. When we looked at primary care, breast cancer risk assessment and risk management for women without symptoms can happen in a number of ways. So one way could be that a patient requests it. It could be that a GP opportunistically decides to raise it, or the woman might have been referred from Breastscreen or other health services. And the GP can then refer women on. They might recommend that they go back to Breastscreen. They might refer them for some breast imaging. They might refer them to a family cancer clinic. They might refer them to a public or private breast specialist or clinic. So there are all these sort of different options that could happen through GP engagement. It's interesting to note that while there are some incentives in place to encourage population cancer screening for cervical cancer screening and bowel cancer screening, the same sorts of things don't really exist for breast cancer screening. And perhaps that's partly about the history of the Breastscreen program, that it has been in place for a very long time as a sort of standalone population screening program, whereas bowel and cervical cancer screening are relatively new, and GPs play an integral role there in recruitment and ordering tests and those sorts of things. However, perhaps as we start to shift towards thinking about more risk-based screening and surveillance for breast cancer, we can think more about an active role for primary care and a really kind of consistent role for primary care in this space. We did note that primary care could refer to a range of clinical practice guidelines, and we spotted some sort of inconsistencies in those. There were some similarities, but some differences, and really quite a lot of clinical discretion as well in terms of what should be recommended for women in different risk groups. And there are a number of risk assessment tools in those guidelines. I think iPrevent might have been added to this list since we did the work, but it was of interest just to note that there was no sort of single risk assessment tool in the guidelines that might be used by GPs. In terms of how it might be managed by primary care, things are fairly consistent for women who were deemed to be more than 3.5 times population risk. So they should be considered for individualised surveillance. But there was a little bit of blurriness for the women in moderately high risk in that, for example, Cancer Australia did have a position statement in 2015 that being more than 1.5 times population risk warrants some sort of individualised surveillance program. What that program is not always very clearly specified, so it could involve clinical breast examination, annual imaging with a mammogram, MRI or ultrasound. So there's a sort of clinical discretion there written into the guidelines. And the family history, we noted that the family history kind of criteria for referral to family cancer centres differed between the RACGP and Cancer Australia guidelines and the EVIQ guidelines that have been developed by the FCCs. We found no advice in these reviewed guidelines about how risk information should be collected or recorded, so should it be on a patient record, how individually assessed risk should be advised to women, what sort of language should be used, for example, and when risk should be reassessed. Now, I'm just a bit concerned about time, so I may dash over some slides, but I will just mention this survey. So there was an excellent survey of clinicians. So there were 12 GPs and 5 practice nurses, so Victorian clinicians in 2016. And they advised that they found that management of breast cancer risk was considered to be a bit beyond routine screening outside of the domain of primary care. But they thought that it could change if experts started to promote the appropriateness of primary care breast cancer risk assessment and management. So there was interest there in becoming a bit more involved with the right support and with the right endorsement. These participants were concerned that there could be issues for patients, that there could be some sort of cancer-related stigmatisation, fear and sense of fatality if risk were initiated by the clinician. Although the authors did suggest that it's probably good to speak to women about this to determine if these concerns are warranted. The respondents thought that risk assessment and advice could be improved through public health campaigns, promoting the availability of interventions to manage increased breast cancer risk. And this could include some education for primary care clinicians. So this study, I mean, it was a small study. There are some other studies that are a little similar to it that really indicate some mechanisms for better coordination, support and endorsement for a primary care role in risk assessment and risk-based management. Just going to skip over that one. Work in New South Wales found that GPs do have a significant influence on women's screening behaviours, with 22% of their respondents saying that being encouraged by a doctor was a key reason to have their first mammogram. Just keeping in mind too that women would have received a direct invitation based on their electoral roll enrolment. They found that women were less likely to screen regularly if they hadn't provided Breastscreen with their GP's details. One thing we noted was we couldn't find any publicly available information about rates of GP referral to Breastscreen or rates of referral from Breastscreen to GPs, or for which is often a sort of so that women could be assessed for potential review by a family cancer centre. So these pathways do exist, but it's really hard from the outside to understand how often they're taken and how they might be evaluated at the moment. So in terms of primary care, in summary, we found that mostly ad hoc risk assessment, it happens as part of GP appointments. Sometimes it happens in response to referrals. We didn't find guidelines about regular risk assessment. There's certainly different guidelines available, but they do differ from one another. Relative to Breastscreen, there's very low quality monitoring and reporting in this area. And we expect that. Breastscreen is a population screening program, but even so, there's significant resources being used here, and these guidelines should be available to all women in a consistent way and in an evaluated way. We found some referral to and from other services, and disparities in access to primary care are well established, and we did document those. But also we noted some disparities, it seems, in how women are referred to different services as well. So we conducted the same exercise for other areas in this map of services that are involved in risk-based surveillance outside the program. For medical imaging, we found that risk assessment tends to be linked to Medicare rebate eligibility. So this means that the Medicare items, the way that they're described is very important. They're quite key drivers in who undergoes risk-based surveillance. We found, again, no guidelines about how regular risk assessment should be. Various guidelines were available. Not very good quality monitoring and reporting, with Medicare items not differentiating between diagnostic and asymptomatic imaging. Some referral to and from other services by medical imaging services. This covers a different age range than Breastscreen. Disparities aren't terribly well evaluated, and there was a key document which was 2018 MBS Review Task Force Breast Imaging Working Group recommendations, which really had reviewed this domain and were recommending various ways to sort of tighten up criteria and more closely regulate the use of medical imaging for risk-based surveillance. For family cancer centres, they had a sort of clearer set of guidelines with the EverQ guidelines and local monitoring and reporting, but not national level that we could see. Of course, a lot of referral to and from other services, a significant self-referral of women to family cancer centres. There have been some great studies looking at how appropriate GP referrals to FCCs are, and quite a lot of those referrals are not so appropriate. And that's partly because GPs say they don't always feel well equipped to decide if a woman is very high risk or moderately high risk. So we've mapped all together and tried to capture how people move between these services, how they might be referred between these services. And overall, it's clear that current risk assessment and management outside the Breastscreen program involves a range of different clinical services with multiple guidelines in place, different recommendations, different risk tools, unclear information on how often risk should be assessed, no current pathways for women at lower than average risk, and overall a potential for women at moderately high risk to be particularly vulnerable to being sort of bounced between services because they're working against different criteria and different recommendations. They might be getting different advice and different risk assessment in different places. And options for women aged 40 to 49 overall are particularly complex, with that eligibility for Breastscreen but not being targeted for Breastscreen, eligibility for some sort of risk-based surveillance services outside the program, and I think probably a closer scrutiny of current services for those women would be warranted. We have to remember here about women's experience of this. So we can think about the services experience, but for women, there are multiple entry points and pathways into screening and surveillance. And we get different advice depending on who they see, where they live, their socioeconomic status, all sorts of things which I've sort of touched on here. The disparities in service access mean that the current disparities in service access would carry over to become disparities in access to risk-based screening unless they're really brought into consideration as we think about making any sort of changes to the health services in this area. And we do have to think about the lifetime experience of women. So currently Breastscreen is targeted over a 25-year period. Of course, women have been alive for 50 years by the time they start Breastscreen. So what would the life course of risk advice, how to look best make sure that if you do get breast cancer, you find it early. What would that look like from a whole health system approach, and how can we improve on that? I'm going to skip over these slides just in the interests of time, but just to say that we're starting to articulate recommendations for how things would need to change, both in the breast screening space and in the risk-based surveillance space outside breast screen, according to these different areas. So I'll move now on to our second topic, which is some findings from the Australian Life Pool cohort. So we had previously, this work focuses on tools for assessing risk at a population level within the Breastscreen program. And one very well established tool in this space is the Tyra Acousic risk assessment tool. Here are the different factors that are included in that tool and the hazard ratios for those risk factors as they're fitted into the model. So you can see, to use the Tyra Acousic tool, women would need to provide quite a lot of information, including things like their height, their body mass index, hormone therapy, the type that they're using, their age at their first childbirth, age at menarche, etc. Some work that we have been doing with Breastscreen under a project called the Bravo project. We undertook some work with Breastscreen clients and with Breastscreen client-facing personnel to think about what routine risk assessment might look like if we were to use a tool such as the Tyra Acousic tool. The client groups reported that they thought it would be difficult to recall some of the risk information that's in those tools. And they would worry about what that might mean if you couldn't remember a particular risk factor. So when you first had your period, does that mean that you would not be managed in the best way that you could? So it's sort of an anxiety-inducing question if you can't get the answer right. Some women said that some of that information would be really sensitive, so they'd want to know why they were being asked and how important it was. Overall, women said they'd really welcome a breast density assessment and being told about their breast density. And we tested some ways that they could be told about that, and providing images really, really helped. For the Breastscreen client-facing personnel, we asked for the different risk factors in the Tyra Acousic risk assessment tool, as well as for the current risk factors that they collect. How well they thought clients might go at providing that information, how tricky it was for them to collect it. And it was interesting, just starting by asking, how well clients report on age or family history. Already we started to see some sort of challenges in trying to collect that information, and kudos to Breastscreen for collecting that for each and every client as they're required to do. So their staff really reported that they really expected there would be challenges in collecting additional information like menopause, hormone therapy, type, age at menarche, and particularly weight they thought would be a really sensitive one. However, they said if a risk factor is justified, and if we really understand that each risk factor is justified and we can explain that to women, if we're given the training, we can do what's required to support it. But without being equipped in that way, it could become very challenging. So this led us to thinking, well, is it really critical to collect such detailed information in a risk assessment tool? And we knew that these questionnaire-based risk assessment tools were first developed without mammographic density, and they've been validated. Versions without mammographic density have been well validated, and that these tools are starting to add in mammographic density. And here's an example comparing the Tyra Acousic model with and without breast density on a large cohort, 132,000 women in the US. And you do see, so that the solid lines indicate the observed risk and the broken lines the expected risk by the tool. So adding breast density improved things a little, tightened things up for the middle 80%, but wasn't really a great deal of difference here. We'd already looked at the Gale model life pool cohort, which is a cohort of over 50,000 Breastscreen Victoria clients. So we're interested to see how the Tyra Acousic model and the Gale model, the Gale model for starters has fewer questions than the Tyra Acousic model, particularly about family history. So this is the two models compared side by side on a large UK cohort. And you can see they're not that dissimilar. So we have the estimated 10-year risk and then the cancer incidence for each of those groups. So it starts to suggest that maybe not, even with breast density added, once breast density is added to these models, maybe it's not necessary to start asking so many questions. And here are the outcomes from our validation of the Gale model on the life pool cohort. So really nice tight fit, except for those upper deciles, which is quite common when these tools are validated on screening populations, because those populations exclude women who are at particularly high, tend to exclude women who are at particularly high risk. So for this work, we looked at women aged 50 to 74 without a personal history, attending subsequent round screening to assess how well existing risk information held at Breastscreen could be used to stratify women into groups of risk, where the outcomes would be firstly incident invasive breast cancer under business as usual screening and interval cancer under business as usual screening. And we wanted to compare this to the Gale model, which we'd already assessed on that cohort, and also to the current Breastscreen Victoria family history policy, which was introduced just a few years ago. So the study group for this analysis was women sampled from the life pool cohort, over 40,000 women in the study group. We excluded women with a personal history of breast cancer, reasoning that they would be managed differently anyway. And for this cohort, if you're not familiar with it, it's a very rich cohort because women have completed a questionnaire and the cohort is linked regularly to the Victorian Cancer Registry and the Breastscreen Victoria Registry, and now the National Deaths Index, and also some Medicare claims for women who've consented. So it's a very rich data set. At the point of this analysis, there was a mean follow-up of 4.2 years for invasive breast cancers. And because interval cancers take a little bit longer to ratify between Breastscreen Victoria and the Cancer Registry, we had a shorter follow-up for interval cancers. So for this analysis, we used photo density measurements from the baseline mammogram for women in the cohort. And then we compared how the different risk models were associated with observed incidence of invasive breast cancer and interval cancers. And for this analysis, at this point, the Gale scores are combined with mammographic density quintiles. We fitted a few different models. So here we have on the left, the factors that are included in the model in summary. And then we split women into 3 different groups. So we have our average risk group, who's they're kind of the remainder once we take out a lower risk group and a higher risk group. So for example, here for the current family history policy, there's no lower risk group. But women who have a strong family history or are aged 50 to 59 are in a high risk group. And these are the women who are currently offered annual screening. Another example, here we have the Gale model, combining age and family history with mammography. So these groups will be different sizes depending on how we'd sort of combine the quintiles of different scores. If we look at the distribution of these groups, so you can see how differently they're distributed. And that means it's important for us to look at the outcomes in a sort of more standardised way. Looking at the estimated 5-year invasive breast cancers by risk group, we can see the sort of order of outcomes as we would expect. And we can see straight away that there is some sort of reduced rate in these lower risk groups by whatever method we used. Another way to look at these same data is to plot them against the population percentile for each of the risk classifications. So this is a way of standardising the outcomes, taking into account how many women are in each group by each risk assessment approach. So it's sort of moving the dots so that they're more comparable. And I guess the thing that really strikes you firstly about this plot is that things overall look pretty similar, except for this blue dotted line, which is the current family history policy, which doesn't have a lower risk group. And then this grey line, which is the combining family history, breast density and age. This line here is also not quite stretching up to higher rates in the high risk group. Now, if we look at interval cancers in the same way, if we don't adjust for the different sizes of the different models, so the different risk groups, we do get a sort of pattern that we would expect to see. And we're starting to really isolate a group of women here who are at a markedly lower risk of interval cancers for the follow-up period that we had. If we then standardise it according to these percentiles, again, we're seeing a number of models are able to identify a group of women at much lower risk of interval cancers and women who are at some higher degree risk, higher than average degree risk of interval cancers. This is the group in a lot of ways that interests us the most. So is there potential here that there could be a group of women who don't need to be screened every 2 years, potentially? If we look at some selected models here, so on the left, invasive breast cancers, on the right, interval cancers, we more clearly see how these models compare to the family history policy. So the two models here are one with family history and breast density, and the other is family history, age, the other is the full Gale model. And this is just a bit of a plot indicating how the outcomes arise over time. So the dashed lines show the current family history model, and the solid lines are the model combining family history and breast density. So we can see how important breast density is for stratifying women into different groups, and these differences become more marked over time. And the same holds for our interval cancers. So this analysis indicates that these simplified risk models incorporating age, breast density and family history may yield the precision required for population risk-based screening. Maybe we ask so many questions. This includes identifying women at significantly lower risk of invasive and interval cancers under the current program. If this simplified approach could be taken, it would really reduce the impost on women and the costs and challenges for breast screen services in risk assessment and advice compared to more detailed risk assessments. For any of these models, mammographic density assessment would be required. So the next steps in this space is some further analysis and validation. We're going into a second phase of the Bravo study where we'll be evaluating some routine risk assessment and advice in the Breastscreen Victoria program. So we'll look at, we will use a more complex risk assessment tool and a simpler risk assessment tool and ask staff and clients what their experience of that form of risk assessment was like for them. We want to, as building off the previous topic, we really want to look a little bit more closely at younger women, so women aged 40 to 49. And of note, any significant change to screening protocols would require a trial. So in no way are these findings indicating we should immediately make changes for any sort of lower risk or higher risk group. However, it does really help us, I think. It does indicating potential to, if we combine risk information rather than looking at things one risk factor at a time, we may be able to isolate some higher risk and lower risk groups within the screening program. So I'm going to pass over to Pietro now.
Over to you, Pietro, but we can't hear you. Good.
Oh, should be on.
Yeah, we can now.
Okay, thank you very much. Hello, everyone. I'm going to give you some a taste of what modeling can, what's happening here. I'll maybe share my screen. There we go. Okay, hopefully you can see the full screen slide. I'm going to give you a taste of what modeling work can provide you, what outcomes can provide in such kind of projects, and I'm going to draw from some outcomes of a couple of past modeling analysis and exercise that we did in the last couple of years. So the modeling platform that we use is called Policy One Breast. It is a continuous time multi-cohort microsimulation clinical model, microsimulation being a particular type of simulation modeling. And it simulates the whole Australian female population. It includes breast cancer risk factor, the evolution and changes in the breast density for each single woman simulated. And it also takes into account the effect of menopause and hormone therapy on the evolution of breast density. It has a dedicated tumor growth and detection submodel. It can overlay the Breastscreen program on the population and alternative to it. And of course, it has heaps of attributes. Each individual is characterized by a lot of attributes, and these attributes flow from the various components within each simulation. And we are also finalizing our treatment model that will include surgery and therapy. And we just finalized our health economic component that will allow us to do also cost effectiveness analysis and quality of life analysis. I'm not going into detail. I'll just stop here for what concerns the technicalities, but I just want to give you an idea of how deep and detailed this model is. The Policy One Breast is part of a larger program that aims at studying multiple cancer with cutting-edge modeling techniques. And you can find a little bit more about the modeling involved in this program on the webpage policyone.org. Policy One Breast provides several outcomes, and these outcomes can, of course, and needs, of course, to be used to validate our model in order that you can trust the results that is given to you. This is a relatively old plot now, but it gives an idea on what can be done with some of the outcomes. Here I'm showing the rates of detected breast cancer for 1,000 women by modality of detection. So going from the left to the right, those are screen detected, interval cancer, and community detected cancer, and then the sum of all of them. And this is a comparison between observed in solid line and simulated data with the dashed line. And this kind of exercise can be carried out for any kind of outcome for which you have enough data for validating the model. So once we validated one of the first iteration of our model, the first test that we wanted to carry out was to model some projections, and we included an hypothetical screening test technology that would be used for all the population, for all the screening participants from the year 2020 onwards. And in this exercise, we simulated 3 different scenarios. One scenario was replicating the current program, indicated in these plots with the dashed line. And then we also simulated 2 scenarios in which we implemented an hypothetical technology that is able to reduce the masking effect of the breast density. That it plays a huge factor during the screening episodes. And the scenarios in which there is a 50% reduction is indicated by the black line, 100% reduction in masking effect is indicated by the gray line. And As you can see from the leftmost plot that is showing the screen-detected cancer, as soon as this technology is activated in the model, there is a huge spike of detection of breast cancer in the screening population. After a few years, this goes down because of the mop-up effect of the hiding cancer in the population that were being hidden by the breast density, by the dense tissue, and then it goes down. It goes down gradually, and actually for longer time period, especially for older risk group, you would see these rates approaching the current risk program and possibly going down in the future. Another exercise that we did last year and took a lot of our time, indeed, we shifted our focus. We were focusing more on the ROSA project, on risk-based scenario, but this was some urgent piece of analysis that was required by the Department of Health, and we were commissioned to do some modeling and analysis of for estimating the impact of COVID-19 on the cancer screening program. The first phase was done with quite urgency, and it was aimed at estimating the impact of pauses of different length on the breast cancer screening program, pauses of 3, 6, and 12 months. And then as soon as observed data became available, we could tailor our model to reflect more closely what was happening in Australia. And so the estimate of recovery scenarios, recovery protocols could have been a little bit closer to, let's say, more reliable, because the basis of the model was more anchored to observed data. And just want to point out a couple of peculiar features that we had to implement for this exercise. The throughput trends that control in our model the screening capacity in function of time, and the prioritization protocol that give a higher priority to specific group of women, in practice enabling population stratification in the simulated cohorts. Just a little bit more details on these two aspects. In the top table, you'll see a combination of the throughput trends relative to business as usual. And we focused on 2 time periods, from May to December 2020, and then from January 2021 onwards, with different service capacities. And we combined these all these throughput trends to create these four scenarios. And on the table below, I'm just bringing up one example of prioritization protocol. We had 5, 6 of those, but this is just one to give an example, and it includes 5 strata. And apart from the higher priority group here that is indicated with rank 1, that includes the annual screeners, then for the other groups, the factor that we use for stratification were age groups, the number of screening rounds, and the period in which the screening events was supposed to happen. An additional layer of complexity was given by the fact that it was not, of course, a business as usual situation. So when it comes on modeling recovery strategies, we had to allocate the service capacity appointments, screening appointments, to the various priority groups. On the left plot here, you can see the percentage relative to business as usual of appointments allocated for a scenario in which we have just one priority group, and this proportion of appointments are indicated by the blue area. On the plot on the right, it is a more complex situation in which we have 5 priority groups, and we had to allocate and calibrate the model so that we can accommodate recovery strategies for all these priority groups. And you notice that, of course, these groups overlap between each other, and we approached these strategies because we didn't want to introduce systematic delays in lower ranks, so that we could minimize details for all the density groups. For all the priority groups. So these are some outcomes from this exercise, and those are relative to screening behavior. And on the top 2 tables, I'm showing what are the screening rates for clients that are coming that had the previous screen in 2018 on the left and 2019 on the right, so that the next appointment would be in 2020 and 2021 respectively. And as expected, and I'm showing these screening rates for all the combination of throughput trends and prioritization prioritization protocols. And as one would expect, depending on the combination of throughput trends and protocols selected, there is a different decrease in rescreening rates. Maybe I need to point out that the blue bars here are business as usual scenario, so we can compare all this combination with the current program. And again, the change in rescreening rates can decrease up to 20% for some selected scenarios, a little bit less for others, but for clients that are coming to screen in 2021, for whatever scenario we selected, the impact was very minimal. And this is also, I have to point out that those are all outcomes for the second phase of the modeling. So the one that was actually modeled was based on the observed data available for last year. On the lower table, this I'm showing the time required for the prioritization protocol. That is actually the time since the service resumption that is required for going back to business as usual, so that all the backlog of clients is being cleared and all of them had their recovery screen. And this time, again, varies according to what combination of throughput trends and prioritization protocol is selected, going from as low as 14 weeks, but it can go up to 40 weeks for some of the scenarios. So you will have effects that are carrying over the 2021 in the next year following the disruption. Of interest are, of course, also the clinical outcomes. On the left side, I'm showing a couple of plots for the phase 1 analysis, in which we analyze what is the impact of pauses of different duration on the screening services. And those are giving us proportion of diagnosis with respect to the baseline, that is business as usual. And those are all for the period going from April 2020 to March 2021, so at least a typo there. And for women aged 50 to 74, all of them averaged. The top plot gives the proportion of tumor size that is smaller than 15 millimeters. And as one would expect, of course, it decreases with the increasing of the disruption of the pause in the screening system. And this is because the early detection that is guaranteed by the screening episode is not, you cannot take advantage of that because clients were not allowed to go screening for that amount of time. So the cancer would progress forward. And this is reflected also in the bottom left plot, which we estimated that the nodal involvement for the detected cancer would increase as the duration of the pause increase. Going back to the phase 2 analysis, we could see also a fluctuation in screen detected cancer even with this modeling. So the business as usual rate here are indicated by the horizontal gray line, and I'm just plotting result for the P0 protocol, prioritization protocol, in which we do not have actually a stratification, but the first clients arriving were the first that would get the appointment. And even with just this, you can see that for the years 2020, 2021, there is an overall decrease in screen detected cancer, and it follows, and then 2021, 2022 follows an increase in screen detected cancer. And for most of this scenario, this is a direct consequence of the delay of the appointment. So we estimate that this is a delayed detection, and so it means that a good part of this cancer could have been potentially detected earlier if we would be, if we were COVID-free. So in practice, what I wanted to show is that the interventions like the one of hypothetical technologies that reduce masking, that is, of course, an exercise that we did, but in our model, we can calibrate the screening test to emulate a real alternative technology. At the moment, the default is 2D digital mammography, but we are including digital breast tomosynthesis, ultrasounds, and MRI as well. So we again have estimate for that. And we saw from our modeling exercise that we have short-term effect translating in that peak of detection, but then it settles over time. So we can also analyze what are the long-term effects there. The COVID impact on screening participation also was estimated to change according to the scenario considered, but also based on the real observed data. And the risk-based recovery is expected to improve some of the outcomes. So given that we prioritized the high-risk group, we expect that the impact on the services on the higher risk group would be minimized by this kind of strategies. But we also noticed that population level increase in cancer size, and this was particularly noticeable for severe disruption, so for longer pauses. And we also, in those kind of exercise, noted a slight reduction in 5-year survival. And overall, there are fluctuations in rates of screen-detected cancer in both of the modeling and that we performed. And just for going back a little bit on the ROSA project and what is the role of this model in this project, just want to point out that we can stratify the population on our platform by different through different factors. So we can use lifetime risk or 5-10 years risk estimate, such that one provided by the widely used risk assessment tool, as those cited by Kaz. And we can use mammographic density, we can use age, and we are also implementing the model to include genetic factors and family history. With that comes, of course, the needs of assessing the risk within the model and the capacity to monitor risk. And so one of the biggest introduction in our model is risk assessment episodes, so that risk stratification follows that episode. And we are using a lot of those factors just mentioned to create several, more than 50 risk-based scenarios within the ROSA project that are going to be evaluated shortly. And all these factors include, of course, change in risk group, in screening tests according to the technology use. We will change screening intervals and the screening participation rates. Of course, we can estimate what would happen if we increase the overall participation rate, but we can also, of course, fine-tune details like risk assessment frequency or targeting the strategies or technologies to some particular age group of interest. And I believe that's all for me. Thank you.
Okay. Thank you, Pietro, and thank you, Kaz, for a great presentation. We're running out of time, but we do have time for a couple of questions. And I might start while others add theirs. As the question of feasibility, and I think you addressed this significantly, Kaz, the feasibility of routinely assessing mammographic density and family history in a screening population. Do you have any comments on that? Do you think this is something that could be done on a population level?
Well, the Breastscreen program already does assess family history at every screening episode, so we know that's feasible. Whether it's feasible to collect more detailed information, obviously that would need to be updated fairly regularly, so that's one that would need to be tested and will be tested through the Bravo protocol to some degree. Mammographic density, I think it should be feasible to routinely assess that and advise women about that, and certainly we'd be aligning with international progress if we were to assume that we could find a way in Australia to do that in a standardised fashion.
And just on that, would mammographic density need to be checked once or repeatedly? Well, is there evidence around that?
So it depends on the way that it's to be used. So the way the breast density relates to breast cancer risk, it's largely about how women are ranked according to their age. So if you have high or low breast density for your age, that's an indicator of breast cancer risk. However, if it's about how breast density might impact the sensitivity and specificity of the screening test, it really is about your actual breast density at the time of screening. So if we're thinking about maybe offering some additional or alternative screening modalities for women with very dense breasts, I would say that the breast density would need to be assessed regularly for that purpose.
Okay. And I do have a question just for clarification for from Pietro. That modelling, those data that you showed about the reduction in the proportion of small cancers and an increase in the number of node-positive cancers, was that modelled predictions, or were they the actual data from the COVID era?
Those are model predictions. So they were coming from the phase 1 analysis that we did last year, in which we estimated the poses of different length. And this is something that we not think it would happen here, because in the end, the length of disruption was way shorter than what we predicted. So those were just estimated for longer poses, for 3-6 months of services poses. So
but just following on from that, now that you've sort of put your prediction on screen, is it likely to be possible that we can get the actual data to see if there is a signal?
Yeah. Look, the first report is already available on the Department of Health website, and for what concerns the analysis done based on the observed data, then the effect on the clinical outcomes are marginal, are really minimal. And this is, we think that is because of the fact that the system was shut down for just 1 month, and then very quickly recovered up to 80% of capacity. So I think that all the effect that we estimated in the first analysis were minimized by this, but I think will soon be available. Yeah.
That's actually reassuring, because it is a little at odds with some recent publicity with the New South Wales Breastscreen being paused about the modelled, dare I say, adverse outcomes of that pause. So we will see.
It's going to be interesting to have further data to use for modelling. Yeah.
Okay. Well, we are just after 1:30. It's a pity we haven't had more time for discussion, but thank you very much for coming along to update us on our work. And I'm sure this is a story that will continue. So we might book you in a couple of years for an update. So thank you everyone for joining. We do have another Grand Rounds in 2 years, and as an underprepared chair, I can't remember who that is, but it will be another excellent session. It will be publicised, and please tell your friends to come along. So thank you again to Kaz and Pietro, and see you next time. Bye.